today. I want to thank also a few people in the audience who work with me in the laboratory, whose work I'll be talking about today, so thank you for coming. Today I'm going to talk to you about endometriosis, particularly some of the work we've done over the last few years. About the role of stem cells in endometriosis. And the message that I want to leave you with, as your last speaker for this conference, is that endometriosis is a systemic disease. What we see when we do surgery is only part of the story, that endometriosis really has a more diffuse presence. And I'll show you that through some of the work we've done on stem cells. Good, thank you. Just let our changes on. Yep. Good. What's it doing? It's okay? Yep. Okay, good. No, it's not changing. Slight technical difficulty. Try it again? No? I'll just advance it. Okay. That's easy. Forget the, I'll be constrained to the podium, but I'll just do it this way. So I think all of us know that the endometrium is a tissue that has this dramatic turnover. Every month with menses, the entire endometrium shed, it regrows from the basalis layer. It's no surprise that this tissue would have some stem cells that would regenerate that endometrium in each monthly menstrual cycle. And indeed, our group and other groups have found stem cells that really regenerate both the stromal cells, the epithelial cells, the endothelial cells, the vasculature, undergo a complete regeneration in each monthly estrous cycle. And these are, we consider progenitor stem cells that are already programmed to develop onto endometrial cells. But a few years ago, we wondered whether other types of stem cells might also contribute to the endometrium. And bone marrow is a rich source of multipotent stem cells. These mesenchymal stem cells in the bone marrow are distinct from the hematopoietic bone marrow stem cells that give rise to the blood cells. But there are also these mesenchymal stem cells that have been shown to differentiate into all sorts of different types of cells, some of which are shown here, and contribute to repair of some organ systems. Well, we thought that if these cells could give rise to so many other different cell types, certainly with a rapid turnover we see in the endometrium, they might very well be able to give rise to endometrium and contribute to endometrial repair and regeneration. So we did some simple experiments in mice and in humans to look to see if indeed stem cells from bone marrow or elsewhere could contribute to endometrium. Here we transplanted male bone marrow into female mice, and very simply looked to see if we could find endometrial cells with a Y chromosome. Very simple experiment, and indeed we did. In the panel A, the control on the upper left, this is looking at Y chromosome by Y chromosome fish. So the little red dots in the nucleus of each cell are the Y chromosome, and that's a male control. And you can see most of the cells have a Y chromosome. About 85% of the cells we could detect a Y chromosome. Depending on where you slice through the cell, you may miss it. So whatever numbers we get are probably a little bit of an underestimate of the total number of Y chromosome-bearing cells. And B is a female-to-female transplant. We looked at the uterus just as a control. You can see there are no Y chromosome-bearing cells there. But in C and D, you can see Y chromosome-bearing cells after transplantation of male bone marrow into females, looking at the uterus. In C, on the bottom left, that cell is an endometrial epithelial cell. The black stripe is the lumen of the uterus, and the epithelium is on either side. And in D, in the lower right, is an endometrial stromal cell that is derived from, again, the male bone marrow that was transplanted into this mouse. And I won't go through it all here today, but we looked at various markers, indeed, to be sure that these truly are cells that are turning into endometrial cells that are transdifferentiated, as we say. For example, we looked at cytokeratin, which is a marker of epithelial cells. You can see the yellow there is the cytokeratin, and that cell on the right with the Y chromosome signal also expresses cytokeratin. So it's an endometrial epithelial cell that is derived from the bone marrow transplant. In the bottom left, you can see a cell that here is colored green. That's a leukocyte. We stained for something called CD45, which is a marker of all white blood cells, and we excluded those cells. We expect after a bone marrow transplant all the leukocytes will certainly be bone marrow derived. But here we show clearly that these cells are endometrial stromal and epithelial cells, and again, derived from bone marrow. And we looked in women as well. We looked at women who'd undergone bone marrow transplant many years before a biopsy, and had some bleeding, clinical indication for a biopsy. These women had all undergone chemotherapy, total body irradiation, and bone marrow transplant in the old-fashioned way, in the old days, where we actually took bone marrow rather than peripherally mobilized stem cells and transplanted that. And then we looked for women who'd gotten a bone marrow transplant with a single HLA antigen mismatch, and we used the mismatch HLA antigen to identify the origin of any cell. And this is in the endometrium of a woman with a bone marrow transplant about 10 years prior to our biopsy, and the mismatch HLA antigen is stained in brown, the HLA antigen of the bone marrow donor. You can see though in the epithelium on the left, those brown cells intercalated into the epithelial layer are bone marrow donor origin, and on the right, stromal cells, the arrowheads pointing to the blue nucleus are the endogenous stromal cells. They don't stain for the mismatch HLA antigen. The brown cells with the arrows pointing to them are the cells that express the mismatch HLA antigen, are bone marrow derived. And the red cells are leukocytes, again, that we expect would be bone marrow derived in anybody undergoing a bone marrow transplant. And we know that leukocytes do migrate in and out of the endometrium in each menstrual cycle. Well, how functional is this? You know, these cells do go to the endometrium. They're not in very large numbers, but can they really make a functional difference? Can they really play a clinically relevant role, or is this just a curious phenomenon? Well, here we took mice and we created Asherman syndrome. So we injured the lining of the uterus. We did it in a very reproducible way where we put a needle into the lumen of the uterus and scraped the uterus and showed that it resulted in some damage to the endometrium. And in this strain of mice, cumulative pregnancy rate is really pretty close to 100% over several months. When we created Asherman syndrome in the blue bar there, we knocked that pregnancy rate down. It was about 30%. Yet when we gave them a massive amount of bone marrow-derived stem cells at the time of injury to help facilitate repair of the endometrium, you could see the pregnancy rate's about 90%. So we're really able to rescue these mice and treat the Asherman syndrome, showing that these stem cells really do have an important functional role in the uterus. Well, how about endometriosis? What role do they have in the disease that brings us all here today? You know, we think most endometriosis arises through retrograde menstruation, and I think it does. I'm not trying to say that it doesn't. You do. You agree? I think, well, we would all agree that that's how most of it arises. But certainly that is a source of endometriosis. But what about endometriosis that we see outside of the peritoneal cavity in areas where you can't reach through retrograde menstruation? What about endometriosis that we occasionally see in the lung, the brain, other places? What about in the old days when men who had prostate cancer were treated with high doses of estrogen? Some of them developed endometriosis. That is certainly not coming from their uterus. It is not hematogenous or lymphatic spread of endometrial cells. There really must be another source. And we reasoned that maybe stem cells could be the source. And again, we did some simple experiments in mice. I won't go through this in a lot of detail with you, but here we created endometriosis in mice. The brown cells on the left or the blue on the right are markers of stem cells from bone marrow that migrated into the endometriosis and continue to propagate the endometriosis and plays an important role in endometriosis. So we think that this probably accounts for some of the endometriosis that we see outside of the peritoneal cavity, but it also continues to contribute on a regular basis to endometriosis in the peritoneal cavity as well. But I think it accounts probably for the majority of disease in those unusual locations, remote from the peritoneal cavity, brain, lungs, where we occasionally find endometriosis. What recruits these stem cells to the uterus? We've started to understand some of the molecular biology and some of the molecules that are involved. To make a long story short, it's CXCL12 is a cytokine, also known as stromal-derived factor 1, SDF1.
And here we look at what we call a chemotactic index. We put the stem cells from bone marrow in one chamber, and we watch their migration through a gel to see if they're attracted to something we put on the other side of that gel in the chamber. And we set our control where we just put the normal cell culture media. On the far left, you can see we arbitrarily set that as 1, the natural propensity of these cells to migrate. But when we put them in media of cells that were obtained from human endometrial stromal cells, you can see it's about an 8-fold increase in their migration. So these stem cells want to migrate through something that is secreted by endometrial stromal cells. When we treat them with ADM3100, which specifically blocks that CXCL12 receptor, the receptor is called CXCR4, in a dose-responsive fashion, we can block that migration. So that proves that CXCL12 is really necessary for that migration. And a matter of fact, if you just put CXCL12 in the well, they'll migrate to that. So it's necessary and sufficient to attract these stem cells to, in this case, endometrial cells. And indeed, the receptor, the bottom left shows the receptors expressed on bone marrow cells, and here on the right, in the center, it's human endometrial cells express the cytokine, the CXCL12. Interestingly, it's expressed at much higher levels in endometriosis. The top graph, you can see SDF1, a sham is the normal endometrial expression, endometriosis in a mouse model after induction, massive levels of this cytokine that attracts the stem cells. If you remove the ovaries, it drops down, it's estrogen dependent, but still far higher than normal endometrium would. Again, you can even detect that protein. This is quantified below, but you can even detect that protein in the serum. The top one is a mouse, and you can see, even though very high levels are made locally, there's enough produced and secreted into the bloodstream that you can actually detect higher levels in the circulation of a mouse, or even in women with endometriosis, shown on the bottom. It's not a lot higher because it's diluted as it gets into the bloodstream, but it is the very, very high local concentrations that serve as a concentration gradient and attract the cells specifically to the endometriosis. Well, we looked at, again, endometriosis and how they attracted bone marrow-derived stem cells. And we asked for the treatment of endometriosis, medical treatment, and here we used the SERM, could reduce the attraction to these bone marrow cells, the engraftment of these cells into the endometriosis, and indeed it did. This is a percent of those Y chromosome-bearing bone marrow cells. You can see it's pretty dramatically decreased when we use medical therapy. So we think that is one mechanism of action of some of our hormonal therapies, is to actually block these stem cells that continue to feed these lesions. But we saw something very different when we looked in the uterus. Now, in animals with endometriosis compared to those that did not have endometriosis, this is without treatment, they attract far fewer stem cells to their uterus. The stem cells are preferentially attracted to that endometriosis. Again, we showed you they produce much higher levels of the SDF1, which attracts the stem cells. There are a limited number of these stem cells in the circulation. We believe that this is essentially a competition for a limited pool of circulating stem cells, that the endometriosis outcompetes the uterus, and maybe one of the mechanisms where we don't get adequate uterine repair, endometrial regeneration, and why we may see decreased implantation in women with endometriosis. What happens when we treat the endometriosis? Well, looking at the uterus here, this is back of the uterus. When we treat the endometriosis, we get a restored stem cell flux back into the uterus. So medical treatments may help to repair the endometriosis. This just summarizes that data. On the left is no endometriosis, no treatment. Yellow is the endometriosis, or rather is animals without endometriosis, but with the treatment it had no effect on stem cell recruitment to the uterus. The red is you create endometriosis in those animals, the uterus doesn't get the stem cells, you treat the endometriosis medically, and the stem cell recruitment goes way back up. We haven't done this surgically, but I'd imagine you'd see the same thing with surgical treatment of endometriosis as well. So it's a novel mechanism of how endometriosis affects the uterus and fertility. we like to think of the endometriosis as a stem cell sponge. Again, it competes with the uterus for this limited supply of stem cells that are important for uterine repair. Well, the other thing we started to ask, if these cells are circulating to the endometriosis, and some of these stem cells persist in the endometriosis, could they also be then leaving the endometriosis? Could there be a bidirectional flow? And indeed, here we looked at, we had tagged cells in a mouse. We tagged them with a fluorescent protein, DS-red, and we looked in the circulation. We sorted these cells by FACS from the blood, and we could detect these cells in the circulation. These fluorescent cells that came from transplanted endometriosis in our mouse model. When we looked at various markers to try and characterize these cells, again, we sorted them for DS-red, so they are all cells that came from the endometriosis that we transplanted into these mice. They have stem cell markers. They don't have hematopoietic stem cell markers. They have mesenchymal stem cell markers. They don't have the markers of mature endometrial cells. The endometriosis continues to give off more stem cells. They also have that CXCR4, which is the receptor for that SDF1 that recruits those cells. So it looks like endometriosis not only absorbs stem cells, but it's giving off stem cells. Where do they end up? Well, the first place we looked was the uterus. And you know, the example we had was in tumors. Often you'll find that cells from a metastatic tumor can actually travel back to the primary tumor. There is some communication there. We wondered if the same thing wasn't happening in endometriosis. And indeed, in this light, you really can't see it well. But the bottom line is by FACS, by looking for the DS-red protein or by immunofluorescence, we were able to see these cells going back into the uterus. And when they reach the uterus, here we use GFP, and this one, it's another fluorescent protein to mark the cells we transplanted. They express markers of epithelial cells, such as here, Wnt7. These cells are, at least some of them go back and become endometrial epithelial cells. But what I want to point out here, let me see if the pointer works. Again, the red is showing cytokeratin, which is a marker of epithelial cells. Here, the green is showing these cells that have migrated from the endometriosis back into the uterus. It's an epithelial cell, but notice it's not in the gland. It's outside of the gland. Same thing here. Wnt7 is another epithelial marker. This green cell expresses that Wnt7, but it's not incorporated in the gland. Same thing here. Again, expresses cytokeratin. It's an epithelial cell, but it's not in the gland. They're misincorporated into the uterus. They go back to the uterus, but it's a defective incorporation and interferes with some of the communication between epithelial and stromal cells that, again, probably contributes to the infertility. Well, if these cells can go back to the uterus, we started to wonder where else could they go. And Elham, who's in the audience here, actually did the work I'm going to show you next. We started to ask if these cells from the endometriosis could go anywhere other than the uterus. And could this perhaps explain, if they do, some of the systemic manifestations that we see with endometriosis? I mean, endometriosis patients complain of a lot more than just pelvic pain and infertility. There's immune dysfunction, there's differential pain sensitization, all sorts of other systemic manifestations of endometriosis. Well, Elham looked in lung, spleen, liver, brain, and bottom line is in those that had endometriosis, these little blue dots here show some of these fluorescent cells that came from the endometriosis incorporated into these tissues. If we look here, the number of cells, it's fairly small, the percentage is tiny, but they're there in the spleen, brain, liver, lung, at fairly higher levels in the liver and lung than the brain, which is even higher than the spleen. So every organ she looked at, and in every individual mouse that she looked at in each of these organs, right, they all had some cells from the endometriosis that were incorporated into these tissues. And I'll show you that here. Here's some of her work that shows in the endometriosis model the DS-red cells. They are not leukocytes. The CD45 is green, that's leukocytes, but you have separate DS-red cells here in the lung, the spleen, the liver, and in the brain. They're all incorporated in all these tissues. So endometriosis is doing a lot more than just causing the disease that we see in the pelvis. So I'll summarize by by saying, again, I think most endometriosis does come from retrograde menstruation out the fallopian tubes and implants in the peritoneal cavity. But it also can come from bone marrow. Bone marrow contributes to the uterus, it contributes to endometriosis, and I put this arrow much larger here because the endometriosis, because of its inflammatory nature and high production of this CXCL12, outcompetes and attracts more of the stem cells than the uterus. So the endometriosis can come from bone marrow. But then once you have endometriosis, it gives off stem cells that can go back into the uterus, but it can go to all sorts of other places as well. And that paper describing this hasn't been published yet, but is under review right now, and we'll hope to have that out soon. I think cell trafficking, particular stem cell trafficking, is really a central feature of endometriosis. Stem cell recruitment for repair of the uterus is inhibited by the endometriosis, and circulating stem cells are inappropriately incorporated both into the endometriosis, into the endometrium, and as I've shown you, lots of other places as well. And exactly what damage that does, or whether that contributes to the systemic manifestations of endometriosis, is something still under investigation. And I'll just conclude by saying endometriosis really is a complex, chronic, systemic disease. What we see when we operate on these patients with endometriosis, although very important and probably the source of most of their pain, is not the whole story. Thank you. Any questions?
Hello. Yeah. Thank you, Dr. Taylor. As some of you may remember, and you would remember, our first meeting 6 years ago was about stem cells and radical excision surgery. Today, as we stand here, there are new informations, obviously, tremendous information. There are two reports. One report came from Harvard that showed the systemic effect of endometriosis on the coronary heart disease. And that was significant. And just recently, we have one more article in Fertility Journal this month about how excision surgery diminishes the cytokines, chemical portion of the inflammation significantly in these patients. Yes. Now we have the cellular component. Yes. It makes me think that what else is coming next. I want to leave that to you. Any questions from the audience? Please. Pinar.
I'm just wondering, when you stop the medical therapy, how long does thank you. When you discontinue the medical therapy, how long does the stem cell recruitment to the uterus persist?
So we didn't do that. Well, all of them, when we treated them and then we sacrificed them and took out their uterus, these are mice. So we haven't done that follow-up study, but it'd be really important to find out. Yeah.
Okay, great, thanks.
All right, what's that?
Yeah, please.
Questions?
Hello, thank you for being here. My name is Melinda from Anchorage, Alaska. I'm just a patient, but this is my second EFA conference to attend here in New York. I'm able to bring from Alaska Regional Hospital and two doctors, Dr. Wynn Counts, a gynecologist, and a neurosurgeon who's doing advanced stuff there. And listening to the presentations, I've been able to. My question is, from what I've learned as a patient with 3 laps, 1 oophorectomy, I have not had excision yet, but I'm sick, and I have a bachelor's degree in science and wanted to go to med school, but I get sick a lot. My question is, do you know how your research could help me when I've learned that I feel like it's an autoimmune disease that does come back, whether it's retrograde bleeding or not, it comes back. I'm sick every 2 to 3 years, and I just want to know how your research could help a patient like me in the state I am now. I'm almost 37, no children, hope always for a child, but I'm not married, so how could your research help a patient like me?
Well, first, thank you for coming all the way from Alaska. That's wonderful. Appreciate you being here. I think I'm hoping that as we start to understand how these cells travel to different organs, that we can start to think about correcting the diffuse manifestations of endometriosis. First, removing the endometriosis will remove some of these cytokines and remove this source of stem cells that are defective stem cells that are getting aberrantly placed in the wrong location. So I think it's informing us how to correct it. But as we start to understand how endometriosis cells and other molecules that come from endometriosis that I didn't have time to go into today are going to the immune system and affecting immune cells. You mentioned the autoimmune component, are going to the brain and affecting pain pathways and pain sensitization, are going to the liver and other areas affecting metabolism. And women with endometriosis, on average, have a lower BMI. They're thinner than women without endometriosis. So it affects your metabolism, it affects your immune system, it affects your pain perception. At least some of that is due to this cellular migration to those areas and other molecules that are secreted from the endometriosis. So as we discover more about that, not only removing it, but we may actually be able then to start blocking those things by blocking those molecules that attract the cells and blocking some of the other molecules given off by the endometriosis that cause these systemic side effects. So I think this is the first step towards really understanding endometriosis outside of the pelvis, what it's doing, all those other manifestations that you've described that you're affected by as well.
I think, I mean, that's the real question, especially for us clinicians, of what can we do to help our patients now. So I'm fascinated by the fact that the SERM seems to help bring the cells back to the endometrium rather than to the ectopic
Yeah, and
places.
I think it's not specifically SERMs, really any medical therapy. I showed you data with SERMs up there, but
Right.
most of our medical therapies seem to do the same thing.
Yeah, but we know that endometriosis is not very progestin sensitive, or tends to be less progestin sensitive.
Correct.
So I'm assuming it was
SERMs work a little better.
Yeah, I'm
and
assuming it was
Lupron works a little better.
bazodoxifene that you
That
used
was,
in
yeah.
there. So
Yep.
that's fascinating. I'm wondering if we should switch to something like Duovi for our add-back therapy with Lupron rather than...
I'm doing that, and we're preparing the case series now.
Beautiful.
We're reporting on Bruce Leslie and I are actually doing that together.
Thank you so much for your
We both
work.
are using Duovi as add-back therapy, and it is superior to, I think, I mean, you know, again, Lupron with most add-backs works pretty well, but the bazodoxifene really has a tremendous effect on the endometriosis.
Hi, thank you for your talk. Throughout the conference, we've talked about endometriosis at multiple stages of a woman's life. We started off by talking about adolescence, we talked about the reproductive years, and we talked about women whose focus is really just fertility, and then pain from fibrosis at menopause from previous endo. But I feel like one group we haven't talked about yet, and I just want, it's more of a comment from you and your thoughts from you rather than a question, is what about the neonatal period? You know, there is neonatal menstruation.
Sure.
And if we're talking about migration and trafficking of stem cells, you know, not every neonate menstruates. Those that are delayed, more post-term, they frequently do. So I'm just wondering how the level of maturation, even from the womb and menstruating as soon as you're born, can potentially affect your risks for endometriosis as an adolescent or later on.
Yeah,
If
I
you
mean,
have
I've
any-
seen, there's data on that
Yeah.
shows those women, or those neonates that have that menstrual bleeding are at higher risk, so it probably is playing a role. But what I showed you here, the cell trafficking specifically that I was getting at, that SDF1 is estrogen sensitive and would be expected to be suppressed in the earlier years. But if some of those implants could survive, they could be the source of one, endometriosis in the peritoneal cavity, but also these other stem cells that migrate from there. So I wouldn't be surprised if that's playing a role as well.
There are two studies.
Yeah.
There are two studies now in the literature of endometriosis in neonates, that postmortem exam on neonates. Yes.
And the correlation with neonatal bleeding and endometriosis subsequent in life.
Good.
Yeah. Good, thank you.